All right, welcome back, everybody. Our next presenter is Dr. Amanda Thompson, Chief of Pediatric Psychology and Director of Pediatric Programs at Life with Cancer, the psychosocial program of INOVA Schar Cancer Institute. In addition, she currently serves as the chair of the Pediatrics Adolescent Young Adult Special Interest Group of the American Psychosocial Oncology Society and has a leadership seat on the Pediatrics Council of the American Academy of Hospice and Palliative Medicine. Prior to her current roles, Dr. Thompson spent a decade as the Director of Psychology and Psychosocial Services in the Center for Cancer and Blood Disorders at Children's National Hospital in Washington, D.C. Dr. Thompson will speak on the silent struggles of childhood cancer patients and survivors, the social-emotional late effects of treatment. Welcome, Dr. Thompson.
Thank you so much, Susan, and good morning to everyone. Thank you so much for having me here today. First and foremost, I have to say that speaking about the social and emotional impact of cancer treatment in children and adolescents is really a giant topic to cover in 30 minutes. So I'm going to try to do it justice, but I'm very much going to ask for some forgiveness in that I'm only able to cover so much. There we go. Okay. So as you've probably now heard at this point, each year in the US, more than 16,000 children and adolescents are diagnosed with cancer. And while cancer remains the leading cause of death by disease in children, there are nearly 500,000 survivors of childhood cancer in the US today. This is great news and certainly a testament to advances in treatment, but it hasn't come without a cost, as over 2/3 of survivors experience one or more physical, neurocognitive, or psychosocial late effects of cancer that may impact their quality of life. And we're going to talk about some of those today. But before we dive in, I want to take a step back and have us reflect on the complexity of the cancer journey. And this complex figure here doesn't even begin to do it justice. Treatment can last anywhere from a few months to many, many years. Some treatments are mainly outpatient, some are mostly inpatient, some are a mix of both. But it's all complicated, disruptive, full of uncertainty, transition, challenges, ups and downs, and so much more. And this cancer journey for our patients disrupts all the normal things a child or adolescent is supposed to be doing. One of those normal things, or perhaps the most normal things, is school. So while I can't talk about all the social emotional effects of cancer treatment today, I hope to give you an overview and focus on those that have particular relevance for an impact on the child's ability to return to, function in, and enjoy their school environment. It goes without saying that a child's diagnosis of cancer is life-changing for patients and families. And as family functioning directly impacts a child's functioning, I have to start there. In the blink of an eye, when a child is diagnosed with cancer, parents and caregivers are asked and expected to absorb piles of complex medical information and to make treatment decisions very quickly, while also trying to manage their own emotions of shock and confusion and the reactions of their children and their families. They have to witness and support their child who may be in pain, who's undergoing painful procedures, surgeries, as they're now fighting a life-threatening illness. They're experiencing sudden changes in routine, making decisions about their jobs. As 30 to 50% of families, at least one parent quits their job to provide care for their sick child. So that brings with it new financial implications, new financial burden. Parents are having to figure out and manage insurance, FMLA, financial stuff, medications, appointments, how to communicate with their family and friends and community and the school, and somehow also support their healthy siblings. Your students, now our patients, are pulled out of everything familiar to them. They're thrown into foreign, unfamiliar, scary environments. Everything that mattered to them, everything that they're involved in stops, just put on pause. They're undergoing painful procedures. They're having surgery. They're being asked to take lots of medicine, many of which don't taste good, don't make them feel good. They're experiencing fear and worry and confusion and discomfort, all sorts of emotions, and faced with so much uncertainty. And while I won't have time to focus on siblings today, that's a whole separate talk in and of itself. We know that they suffer and struggle too, and you may have some siblings in your classrooms. They have concerns and fears for their brothers or sisters. They're in the thick of the disrupted roles and routines within their family, now having less contact with their brother or sister and with their mom or dad who may be at the hospital for extended periods of time. The older kids in particular may have added responsibilities and expectations at home. Siblings are wondering, who's going to stay with me? Who's going to pick me up? Is my brother or sister going to be okay? Are they going to die? Why do they get all the attention? Am I being punished for something I did to my brother or sister? And in some cases, siblings are also being called upon to serve as a donor for a stem cell transplantation, which can include all sorts of ethical or other psychosocial concerns. So beyond this descriptive introduction, we have decades of research that document the impact of a cancer diagnosis on the psychosocial functioning of children with cancer and their families. What we have learned is that children are incredibly resilient, and that because of that, most kids adapt and cope quite well. There are a wide range of coping strategies that they use and that work well, and there isn't a single best way or a one-size-fits-all that I'm going to tell you about this morning. We do expect there to be some short-term distress reactions at various time points along the cancer trajectory, certainly at diagnosis, at any moment of relapse or recurrence, and also during that transition off treatment. We know that family distress, so with parents and caregivers and the patients themselves, it's typically highest at diagnosis, and then it generally returns to baseline over the course of that first year of treatment. So while most children and families are resilient and do quite well, consistently, there's a small but significant group, about a quarter to a third, who don't cope quite as well and who experience significant levels of psychological distress that may require intervention. And there are factors that have been identified, like diagnosis, treatment intensity, prior psychosocial functioning, family factors like family conflict, financial stability, levels of psychosocial support, other concurrent stressors that we know impact adjustment during treatment and can contribute to more or less distress or that family's ability to cope. We also know that there are a wide range of typical and natural social, emotional, and behavioral reactions to life after treatment. These are expected and important to consider and know about. So our early and long-term survivors may experience things like excitement and hope and relief, but at the same time, they may experience distress and worries and anxiety. They may experience some hypervigilance around their bodily symptoms, where now every bump or bruise or ache or pain is something to be worried about or feels like a warning sign, because they're frequently thinking about cancer and their cancer experience. And fears of cancer recurrence are incredibly common. And this is not just for the patient, but very much for the parents as well. There's something called scanxiety that comes up, and this is the anxiety that surrounds the maintenance scans that have to happen, the MRIs, and the tests and procedures that come up. A lot of concerns about the future, particularly when it comes to dealing with those late effects. A lot of uncertainty about the future and what that's going to look like and what that means. There's an emotional fatigue and exhaustion of having gone through what they've been through the last several years. There's still a lot of emotional processing that has to happen. There can be a loneliness and a social disconnect, and we'll talk about that in just a bit. There's some difficulty returning to school or college or work or life activities. There can be some survivor's guilt in having survived a disease that maybe some of the friends that they've met along the way were not able to survive. Questions can come up, those bigger existential questions about life and meaning. And often along the way, in processing everything they've been through, our survivors can find meaning in their journey. When it comes to psychosocial late effects, we know that survivors are at risk for a range of psychological symptoms, including anxiety, depression, post-traumatic stress symptoms, low self-esteem, and somatization. Somatization is when we're experiencing psychological distress as physical symptoms. And it seems that being diagnosed in adolescence in particular increases the risk for many of these concerns. Research also shows that survivors experience a number of social challenges, including more social isolation and social anxiety. They're less accepted by their peers and participate in fewer social activities. Brain tumor treatment in particular often results in challenges in the area of social competence, with survivors of pediatric brain tumors demonstrating trouble with social awareness, reading social cues, and social problem solving. And as you can imagine, this has particular implications for peer relationships and peer acceptance in and out of the school environment, and also for future romantic partnerships. Now, you've just heard about the cognitive impacts of disease and treatment, so I'm not going to spend time here, except to emphasize that neurocognitive late effects, like the ones listed here, while obviously impacting academic performance, also contribute to emotional distress. Things like anxiety in the education environment, ability to perform academically, but also to low self-esteem and more. I'd be remiss if I didn't mention the education outcomes, because again, those contribute to emotional distress in those environments. We know they're both direct and indirect effects of disease and treatment and that impact academic progress. The rates of absenteeism are actually about 4 times higher for children with cancer than the general school-aged population. In addition to the cognitive impacts, fatigue and other side effects are making it difficult for survivors to concentrate and keep up. We know that survivors are more likely to repeat a grade, which is not unexpected given the above. And they're more likely to use special education services, which I actually think is a really positive outcome, given that we want and encourage all of our patients and survivors to have and utilize IEPs and support services. And lastly, studies show a relationship between more neurocognitive impairment and lower educational achievement overall in our survivors. And that, unfortunately, not unexpectedly translates to less full-time employment in adulthood and less household income. And all of those outcomes are related to psychological outcomes as well. Sorry. So when it comes to school reentry after diagnosis, what do we know? Researchers and clinicians agree that a return to a student's school can facilitate a sense of normalcy, improve health-related quality of life, and promote positive adjustment, academic progress, and socialization of the child or adolescent with cancer. So this is the good news here. And because of that, children with cancer should return to their school and the community as soon as they're medically able. Although it has to be said that there is considerable variability between individual providers and across oncology programs regarding what constitutes a timely return to school. And in addition, return to school is very much dependent on family comfort, as that's quite variable as well. Because there can be some challenges, and the child and family and teachers and school systems are likely to need some guidance, school reentry support has now become a standard of care in the field. School reentry can happen at various points along the trajectory. So we're going to take a minute to look at that return to school from the student's point of view. Early on, when a student is out of school around the time of diagnosis and the beginning of treatment, they're often out for an extended period of time, perhaps on homebound or receiving services within the hospital school program. They're missing class, potentially falling behind. They're also missing sports, activities, school-related events, maybe some of those major milestones. They're missing their friends and opportunities for socialization. Moving forward in treatment, more towards the middle of treatment, pushing towards maybe the end of their more intense treatment, they may return to school at certain points, but there's going to be frequent absences, perhaps for regular appointments or maybe admissions for fevers or other side effects. Your student's going to be excited to go back to school, but probably also a little scared, a little worried about what that's going to be like after being out for some time. They're probably going to struggle to keep up as side effects are still common and interfering with their day-to-day. They may get lots of attention from their peers, which maybe will feel nice, but also could be uncomfortable and awkward. And we hear that a lot from our teens, that they actually don't want to stand out, and that doesn't feel so great. They're also trying to reconnect with their friends that they've been apart from for some time and figure out what they've missed in that social space. And it's not uncommon for teachers to kind of go easy on them when they first return. Coming off treatment, making that initial transition off treatment, it's an exciting time, but it can also be really scary and kind of unsettling as it's sort of trying to figure out what the new normal is going to look like. So they're returning to school, and at the same time, maybe now there's less attention from friends, and perhaps even less understanding from their friends and maybe even from their teachers. And because of all the missed time, they're struggling to reconnect with their peers, struggling to catch up. They feel behind and maybe even a little lost. And finally, during that survivorship period, we see students struggling again with their peers, struggling to feel connected, and really now dealing with the long-term physical and cognitive changes, which are really starting to impact their academic, social, and emotional functioning. So overall, what we know is that a timely return to school is recommended, but reintegration is going to be difficult for some students as social, emotional, and academic challenges are common, especially for those that are diagnosed in adolescence or with brain tumors or diseases that impact the central nervous system. Being a patient or survivor can feel lonely. While they're trying to get back to normal, they feel and look different. They stand out when they just want to fit in. They may not be able to participate in some age-appropriate activities and may struggle to keep up physically, academically, socially. And because of all this, they will need your support. So in the last handful of minutes here, I want to talk about that and how you can support your students' social, emotional, and behavioral needs, and by extension, their parents and families. And first, I'm going to remind you to consider the whole picture, right? Cancer is one piece of that picture. It's a big piece of the picture, but it's one piece. And there's some developmental considerations. How we support a child must involve consideration of their developmental stage and needs, as certainly you all know that the needs for a 4-year-old are very different from the needs of a 14-year-old. We also know that disease and treatment can impact the course of development. And because many of our patients' treatment can span many years and therefore many grades in school, those needs are going to change over the course of development. We have to think about those transitions, right? If a patient is in treatment for many years, that might include the transitions from elementary to middle school or from middle to high school, where those needs are going to look very different. Another piece of the puzzle or the picture is the family system. Cancer doesn't happen in a vacuum, and it impacts the entire family. How the family is functioning impacts the child and vice versa. You all know that when a family is experiencing upheaval of any sort, a child brings some of that stress with them to school. So cancer is very much going to exacerbate pre-existing family stressors, and some families are better equipped to manage new stressors. They may have more resources and supports, and others may be more under-resourced, have less support, and are going to feel that stressor more intensely. Certainly, as you all know, one of the keys to engaging in a collaborative and productive teacher-family relationship is communication, and that's very true here as well. As consistent with the standard of care in school reentry, I'm going to encourage you to open a line of communication with the healthcare team, certainly as the family allows, as consent is needed, and then to check in regularly with the student, the parent, and that healthcare team. One of the simplest things you can do, and this is especially helpful for our teens, is to ask. Ask how your student wants to be supported. Teens, as you know, have very strong opinions about most things, and they will tell you. They will let you know if they just want to be treated like every other student, or if they need a little extra time getting from class to class, or if they need a break throughout the day, or something else. I think it goes without saying that you have a powerful influence on these children's lives. So having empathy, listening, and validating your students' emotions will be so powerful, especially during those tough days and moments of frustrations. I want to encourage you to avoid those phrases that can unintentionally feel quite invalidating, that don't cry or don't worry, or phrases that just aren't true, like I know how you feel, or that we can't guarantee, like it will be okay. And instead, just use simple statements like, this must be so frustrating. You've been through so much. Or my favorite, tell me more, as that helps just reinforce having more conversation. The school environment overall helps to support a child's sense of normalcy, routine, and structure, which is so helpful during a time when everything really feels quite abnormal and unpredictable and unfamiliar. While your first instinct might be to throw all academic expectations out the window, I want you to consider that that can be really destabilizing for children and even a little scary. Reasonable expectations are actually helpful as they help to reinforce that sense of normalcy. I had a teenager once tell me that her one teacher who graded her English assignments the same way she did before her diagnosis gave her hope that not everyone had given up on her having a future. Given the social challenges we discussed, think about ways to foster inclusion and celebrate diversity in all its forms, and ensure that your school has a zero tolerance when it comes to bullying. As you now know, some patients will struggle more significantly and need additional support. So be on the lookout for social, emotional, or behavioral stress that is really impacting a child's functioning, happening sort of so often, more often or more intensely, that it's impacting a child's functioning, their school performance, their ability to participate in school or activities or engage with their peers, something that really feels different than the child that you have gotten used to. So this might look like a young child that is showing signs of severe separation anxiety when their mom tries to leave school. Perhaps a student who reports stomach aches or headaches before every test, quiz, or recess or gym class, or something else. A teen who stops engaging with their peers, sitting alone at lunch, not interested in the things that they used to enjoy. These are the kind of red flags that we look for, the signs of distress that let us know that more intervention is required. Additional supports and interventions also include tending to academic needs through formal accommodations, and obviously you're going to hear more about that. Many students will have IEPs, and I would argue that all should, but I'm going to encourage you to consider inclusion of social emotional goals to support this reintegration and psychological support. Academic testing and tutoring and study skills courses in groups, college and career counseling are going to be important for proper placement and planning for the future. And obviously that all supports that psychological piece as well. For those kids who need additional support and intervention, if your school has the resources, offer individual counseling with your school psychologist or counselor. or provide flexibility for that child to attend sessions outside of the school environment. That may require early departure from class or late arrival to school in the morning. You can also consider other support needs, like simple check-ins and touch points with a trusted teacher or coach. Depending on what you may have available, consider social skills training options or support. Does your school have social skills groups or peer buddies or similar programs to help facilitate social awareness and reduce isolation? And finally, continue to partner with that healthcare team, as well as local and regional cancer organizations like ASK, to understand what other supports are available for the students. For example, there are virtual and in-person groups for survivors, summer camps for survivors, siblings, and families, and so much more. So as I wrap up today, I just want to reiterate that children and families have ongoing, multifaceted psychosocial needs during and after treatment for childhood cancer. Most children and families will cope and adapt well, but certainly some will have more significant challenges and require a higher level of support both in and out of the school. You are very much a part of the student's care team, and your support is critical to their short and long-term adjustment. So I just want to thank you all for your partnership. The fact that you are here today listening to these talks lets me know just how much wonderful partners you all already are, and I can't thank you enough. So I'll stop there and just see if there's any questions.
All right, while we wait for questions in the chat, give people a chance to type those in. I wanted to ask, I often hear from parents that the transition into survivorship is harder, at least for them as parents, than actual being in treatment. I guess because when you're in treatment, it's just like you're just surviving, you know, and then you make that transition and it's like now you're dealing with, you know, all the emotions that were there the whole time. Do you find that to be true?
Absolutely. And I think this is something that for a while, even as providers, we didn't really recognize quite as much. We thought, obviously, you know, diagnosis is so hard, but that transition off treatment is really now being defined as a major stress point. And it very much is the case because, you know, while we think of it as an exciting time, treatment is ending, this is so wonderful. Families really experience it as quite scary, right? They've gone for many years with all of the support and reassurance from their physicians, from their care team, their psychosocial team, regular check-ins, regular appointments. And as they transition off treatment, much of that goes away. And the loss of that support, the loss of those regular check-ins, those visits to the hospitals that provide that reassurance to families that things are going well, that their child is continuing to be healthy, can be really destabilizing and can cause a lot of worry. And so absolutely, I think that is very much a stress point. And that really can be a time, I will tell you, definitely in the outpatient therapy setting, we are often caring for parents, providing them additional psychosocial support during that transition time. And as I mentioned, that's also a time where that sort of processing starts to happen. You know, when caregivers are providing care for their child during the active treatment phase, you're often in kind of executive parent mode. You're just going from one thing to the next because that's what you have to do. And then as it starts to slow down, you have to take a moment, and that's when kind of the emotions start to catch up. So, you know, finding some extra support during that time, I think is certainly recommended and can be a really good time to do that. As some of the other responsibilities lessen, it's a really good time to take some time to process everything that you and your family have been through.
We do have a question that came in. This is a great question. Do children who get diagnosed and go through chemo when under the age of 2 deal with these challenges if they don't remember much of it?
Yeah, it's a great question. And so certainly, you know, it's far less from a psychological standpoint. You know, there is a little bit of a protective factor being younger and having, you know, kind of a less of a salient memory for some of these experiences. Now, the caveat is that we know that under 2, if you're having a treatment that is that impacts the central nervous system or the brain, the impact on a developing brain will unfortunately increase risk for cognitive late effects. And so those impacts will look different. And so there could be some social impact of that, certainly going to be some differences in thinking and learning that could contribute to some psychological challenges in the future. But overall, really, when we think about some of those higher risks for anxiety, depression, post-traumatic stress, much of the research supports that.